My name is Emily Bascom, and I will be presenting the paper Designing Communication Feedback Systems to Reduce Healthcare Providers' Implicit Biases in Patient Encounters. Implicit bias based on a person's gender, race, ethnicity, socioeconomic status, weight, height, and other aspects of a person's physical characteristics and perceived identity can lead to health inequities. Although often unintentional, healthcare providers' implicit bias is associated with poor patient-provider communication, reduced patient satisfaction, and a lack of patient trust in providers, which can negatively impact healthcare access, care quality, and inequitable outcomes. Healthcare inequities associated with implicit bias are most visible in patients from marginalized communities. Discrimination and biases towards Black, Indigenous, people of color, BIPOC, and lesbian, gay, bisexual, transgender, and queer questioning, LGBTQ+, patients are widely documented, motivating providers and healthcare institutions to implement educational support and tools to mitigate disparities resulting from these biases. Despite the growth of implicit bias recognition in management curricula and training interventions to address health disparities and advance equity, approaches to implicit bias instruction have mixed results. Disparities found in patient-provider nonverbal communication suggest that focusing on communication feedback tools to support providers in communicating more effectively with people from marginalized communities may provide a means for reducing the impact of implicit bias in healthcare. Here lies an opportunity through which artificial intelligence and other advanced computing methods can be applied to reduce the impact of implicit bias. Gathering provider perspectives on the design of this technology will help uncover and address barriers to implementing these tools to raise provider awareness of the potential for implicit bias to shape patient interactions and manage the impact of implicit bias during healthcare interactions. Based on this existing work, we centered our research around the question, what are primary care providers' preferences on design features for tools that provide feedback on implicit patient-provider communication biases during clinical interactions? Through design interviews with primary care providers, Dirks and colleagues identified 3 concrete modalities participants recommended for delivering communication feedback that raises awareness of implicit bias through digital tools. First, data-driven feedback, then digital nudges, and finally, guided reflections. Leveraging this related work, we created the wireframes used in this study, which illustrate Dirks' 3 design concepts for feedback on patient-provider communication biases. We also incorporated the design considerations of Loomis and Montague such that feedback should be presented to support provider growth, the timing of critical feedback is important to consider, and feedback should be integrated into short and long-term provider workflows. We collected data through an online survey and a 1-hour remote individual design critique session conducted via Zoom. The online survey collected information about demographics, clinical practice experience, and 2 published measures, including the day-to-day unfair treatment subscale of the experience of discrimination measure and a measure of bias awareness. Part 1 of the design critique sessions consisted of presenting wireframes to participants and asking them for feedback on the features of each wireframe by describing how they envisioned the wireframe's general use, context of use, and desired features. Throughout the rounds, we presented different types of communication cues and visualizations to find the most valuable cues for providers to depict their interactions with patients. Part 2 consisted of collecting participant thoughts about the implications of implementing tools like the ones represented in the wireframes in clinical practice, focusing on how to make the feedback provided actionable and any anticipated personal or institutional barriers. This protocol was pilot tested and refined with 3 researchers not involved in the study design. We summarized survey data with descriptive statistics to characterize the 24 participant sample. We iteratively analyzed design critique session data using thematic analysis. After each round was completed, one research team member compiled participant feedback collected in the note-taking template into a Miro board for collaborative deductive thematic analysis. The board contained a picture of each wireframe presented to the participants for a given round, sticky notes with participant quotes about each prototype, and implications of prototype use. Using this board, research team members conducted a 2-hour remote synchronous affinity diagramming session. This process involved team members individually reviewing the feedback for a wireframe, documenting themes that emerged to them, and then coming together to discuss themes until a consensus was reached about the most important takeaways from participants' input for every wireframe to inform the changes needed to be made for the next round. We will now present our findings, first looking at the evolution of the wireframes based on the feedback received throughout the sessions, and then diving into the implications of these tools, looking at how to make the feedback presented actionable and anticipated institutional and personal barriers. After conducting 4 rounds of design critique sessions, the data-driven feedback wireframe maintained 2 distinct views. First, a multi-patient view where providers see information about the communication patterns across all of the patients they care for, and a patient-specific view where the providers can see in-depth communication patterns with a specific patient across that patient's visits. Nearly all participants preferred the data-driven feedback wireframes over the real-time digital nudge and guide and reflection wireframes. Across the sessions, 14 of the 24 participants prioritized comparisons of various patient demographics throughout the data-driven feedback wireframes. For instance, Patie explained that the information presented could be illuminating, as it might show that there is some disparity and that they are interrupting one group over another. P10 also highlighted these dashboards may help them adjust their perspective from, quote, I am having less luck on counseling a certain group of patients on a certain disease, end quote, to a place where they recognize, quote, it has less to do with the certain group of patients, but the way I relate to them, end quote. Beyond patient demographics, most participants also wanted to see comparisons and changes regarding to their communication behavior over time, with P5 elaborating that these habits of adjusting their communication with patients take a while to sink in. Regarding the communication features presented in these dashboards, most of participants wanted evidence on why the presented features are the most meaningful and accurate measures for depicting the nature of the interaction with the patient. P2 explains, not all interruptions are bad. The reality of a visit is that I've got 15 minutes, but sometimes interruptions are what you need to do to get the information. These participants felt that the values of the communication features presented alone lacked the context they needed to be meaningful and actionable. Furthermore, these participants sought more information about the ideal or desirable metrics for these communication features. Participants across rounds also described differences in cadences for which they would want to review the patient-specific and multi-patient data-driven feedback. However, most did not want to receive feedback during the visit while the patient was in the room. Most participants mentioned how feedback during the visit could be distracting, overwhelming, and confusing, with P20 stating that to try and recognize a certain behavior in real time and make an adjustment, that's tough. 11 of the 24 participants explicitly mentioned envisioning themselves reviewing the dashboard before or after a visit, with P14 explaining how, quote, looking at this before a patient visit may be helpful to frame behavior, end quote, going into an interaction. The real-time digital nudge wireframe was designed to inform providers about their real-time communication behaviors during their patient encounters. This wireframe was depicted in various modalities, including a smartwatch notification, ambient light changes, and a digital picture frame with a tree that would grow and blossom. Overall, this wireframe elicited a variety of impressions and was least preferred compared to the data-driven feedback and guide and reflection wireframes. The final iteration of the real-time digital nudge emphasized highlighting what providers were doing well in an interaction to encourage more desirable communication behavior and reduce the potential implications of a patient noticing the intervention. While some participants had positive impressions regarding the general use of the digital nudge, stating that a tool is a, quote, nice encouragement of good behavior, end quote, most participants expressed much hesitancy about implementing a feedback tool like this in exam rooms during patient visits. The main concern for these participants was the potential for the digital nudge to be distracting to both the patient and the provider. P20 explained, quote, feedback in real time is really tough. There's a lot going on in a visit, and both the provider and the patient have a lot to address, which may make it difficult to pay attention to the digital nudge in a meaningful way, end quote. P5 elaborated, stating, quote, it feels counterintuitive and somewhat ironic that you're telling somebody to look away from the patient at their watch to tell them to look more at the patient, end quote. As an alternative solution, P14 and P16 expressed being interested in having their communication behavior shown to them after a patient visit or at the end of the day, rather than in real time during the visit. For example, P14 remarked that it would be nice to have a summary at the end of the day describing, quote, you had really good interactions because you did XYZ things with your body, end quote. The initial guide and reflection wireframes depicted in-person or chatbot debriefs by reflecting on video snippets of patient interactions that could be improved. Participants in the first round of design critique sessions immediately pushed back on this wireframe, explaining that while seeing video snippets of the interaction would be helpful, frequent guided debriefs would be onerous and too much of a chore, with little to no advice about improving their interaction. Additionally, these participants explained that this type of review would be too time-consuming. To address this, the wireframe evolved across the 4 rounds to be a, quote, quick tips page, based on trends in the provider's communication behavior. They'd be shown 5 tips or things to think about with the option to learn more by reading an academic paper or another resource. A vast majority of participants described wanting tips and recommendations personalized to their specific behavior with patients. Participants viewed the Quick Tips page as a valuable educational resource, envisioning the feedback they received from the data-driven feedback tool being paired with the information in the Quick Tips page to serve as a way to debrief and determine opportunities for improvement. Participants were interested in seeing deep dives on patient demographics. Quote, if you find that you have a subset of patients that it's consistent where you're scoring lower, then maybe you could kind of look at some of the characteristics that happened during those visits, and you might be able to do some pre-visit planning. That's a little bit different. But how can I readjust to improve things there? And this might be where coaching or some kind of educational thing can help out there, end quote. 4 of the 24 participants specifically mentioned incorporating the Quick Tips page into their continuing education requirements, with one provider mentioning its use as a potential way of receiving credits for diversity, equity, and inclusion training. Most participants worried about having the time and/or institutional support to engage with the guided reflection tool. However, some participants also thought that the Quick Tips page would be especially helpful for students or residents who may have more time to review their feedback. As P18 stated, quote, I could see this as useful during the professional development of young physicians. If I were in practice, this is too busy, but in an educational setting, this would be useful, end quote. Most participants wanted actionable, personalized feedback on improving their implicit communication bias. Examples participants described were succinct feedbacks, graphs, and tips for improving their behavior, information on what to do following receiving feedback, supporting educational materials on why certain communication behaviors matter, and having the informal opportunity to choose to discuss the feedback they received with other providers or trained professionals in a non-punitive way. Participants largely focused on the Quick Tips resources, wanting to see support through courses, communication coaches, readings, podcasts, or videos that are presented in a way that encourage provider wellness and improvement. Furthermore, participants identified a clear beneficial link between the data displayed in the data-driven feedback views and Quick Tip pages. Participants also wanted to compare metrics across in-depth patient demographics and have their behavior patterns linked with specific patient groups to suggest actionable ways of improving their behavior through the Quick Tips page. They were interested in seeing how their communication behavior changes over time to document their progress and provide motivation for continuous improvement. While the opportunity for actionability based on the data-driven feedback and Quick Tips wireframes were clear, a vast majority of the participants anticipated the real-time digital nudge wireframe may inhibit their ability to meaningfully engage with their patients during visits by serving as a distraction to both patients and providers. Participants described institutional and personal barriers they anticipated may arise when implementing an implicit communication bias feedback tool. Participants were worried about having enough time to effectively engage with implicit communication bias tools during practice hours, especially if providers were not incentivized or compensated for this time. 3 participants proposed that if the tool was integrated within the institution's electronic health record, or if the tool was paired with an organization's diversity, equity, inclusion initiative, it may help overcome some of those barriers. Participants explained that they also worried about the data collected by the tool could be used punitively by their supervisor insurance companies based on how providers perform. Echoing through participants' responses is a desire to be a better provider to all patients, but also an honest recognition that there are only so many hours in the day. Many providers welcome feedback and find it important. However, feedback should be actionable, presented to support provider growth, allow for adequate processing of critical feedback, and be integrated naturally into provider workflows to not distract providers from their clinical work. Providers recognize that tools similar to the wireframes could be a great opportunity to learn how they communicate with patients. However, an additional tool or requirement in exam rooms and clinics is likely to elicit scrutiny from providers, especially if there's a potential for it to become punitive. Rather than forcing a solution that may lead to further provider burnout, we suggest the integration of the tools and technology described here with the pre-existing education requirements providers already must complete. Our findings describe a clear opportunity to enhance patient-centered communication curriculum with personalized feedback on how each provider communicates and the unique populations they serve. In summary, after conducting 24 semi-structured design critique sessions, we learned that participants preferred a feedback dashboard with actual educational resources to review outside the context of patient visits. Here we expand upon existing literature surrounding providers' preferences on how to design communication feedback tools with a focus on historically marginalized patients to refine these design preferences while integrating innovative computing methods, social signal processing generated interfaces geared towards raising awareness of implicit bias that consider the design preferences of providers. Thank you.